Appreciate everybody joining us today. We're very excited to have Dr. Jennifer Hutchens back with us. She's going to do an excellent presentation for us today. She's actually done this for us once before, and we wanted to get it recorded and added to our resources that are available to all of our members around the state. So she's been very gracious to join us once again. Just a couple quick housekeeping items before we get started. As I said, we will be recording today's session. It will be available on our YouTube channel later this week once we have got the recording processed. If at any point during the presentation you want to ask a question, you can either use the chat function, which I will send a quick message to everybody so you can see how that works, or you can use the Q&A function. Both of these are accessible by hovering your mouse over the screen. They should pop up either at the top or the bottom of the screen, depending on what view mode you're in. And during the presentation, I will keep an eye on it and moderate for Dr. Hutchens so she doesn't have to keep checking them as she goes along. If we have any questions, we will definitely take care of those at the end of the presentation. So without further ado, I will start the recording. And thank you, Dr. Hutchens, for joining us.
Thank you for having me this morning. What a privilege to be able to present for the Indiana Rural Health Association on the psychology of pain management. It's something that I do every day, and it's something that is vastly important, and we're starting to see more and more research come out about how important the psychology of pain management is. A couple of housekeeping things to get out of the way first. This is a CE presentation, and just so you know, April 15th, the governor lifted the restriction of distant learning requirements for all healthcare providers, simply because of the COVID-19 state of emergency. And so what a wonderful opportunity to be able to get some online CEs and some excellent presentations from the safety of your home. So I just wanted to let everybody know about that. That order was signed on Wednesday, April 15th, and is on the Indiana website, and I'm sure on the healthcare providers' different licensing websites as well. This is sponsored by not only Indiana Rural Health Association, but the CEs are offered through the Indiana State University School of Nursing, College of Health and Human Services Continuing Nursing Education Program. Let's see if I can advance my slide here. In order to receive, there it goes, it's going too fast now, sorry. In order to receive continuing nursing education contact hours, you must complete and sign a verification of attendance form, and also an evaluation form must also be completed. Neither Indiana State University School of Nursing, continuing nursing requirements. I don't know what's going on with my advancement, but if you know me at all, you'll know that we just kind of work through these problems, even if it is being recorded. So, nor Indiana Rural Health Association has any conflict of interest among planning committee members or the presenter. They do not have any commercial support for this offering, and they are an accredited provider of continuing nursing education credits. Sorry, let's get to the role of psychology and pain management. We'll get through this. So the role of psychology and pain management is vastly important. And what's interesting is that we're not really used to seeing a psychologist or a therapist that is embedded in primary care settings. However, what happens when you have that is just a holistic care for the patient. So we want to make sure that we explain why this is important, particularly in pain management, especially during the opioid crisis, when we're going to see a resurgence of pain because of the limitation of prescriptions of opioids. So first we have to understand, though, what pain is. According to the Institution of Medicine, at least 100 million adults in the United States suffer from chronic pain. Chronic pain affects more Americans than these combined, which is diabetes, heart disease, and cancer. And so when you think about the primary care field and what we're seeing a lot of pain. Chronic pain affects more people combined than diabetes, heart disease, and cancer. It's important to remember that pain is useful. When we feel pain, the body's oh my gosh, the body's way of telling us that something is wrong. And so it's interesting that we have to then use it to help us, but also then when it becomes chronic, it becomes a problem that actually hurts us. Chronic pain is complex. Medical treatments and psychological treatments are important. And the last thing to remember is I am not going to talk you out of your pain, okay? I tell that to every patient when they're confused about why they are sent to me to do therapy, is I'm not going to talk you out of your pain. When I find that magic conversation, I'll patent it and buy an island, and that's where I'll do therapy. But until then, I'm not going to talk you out of your pain. However, there are things that we can do to reduce the pain. And so I want to show you a little exercise. A lot of times when people are in chronic pain, it's a lot of thoughts come, I shouldn't be in this much pain. So I want you all right now to think of something that you don't like about your life and start saying, I shouldn't be experiencing this. A lot of times it comes with the COVID-19 crisis, right? Is I shouldn't have to stay at home. I shouldn't, have to socially distance myself from others. I shouldn't. And so when you say those I shouldn't be in this much pain, I want you to notice that as you're saying that to yourself, how tense your chest gets right here. It's a teleso. And then how tense your shoulders are and how much your brain is fighting the fact that you are social distancing or in chronic pain or don't like what you had for breakfast or, things of that nature. The body tenses up. Because when we say, I shouldn't be in this much pain, then your body goes into the fight or flight. And when it goes into the fight or flight, it's going to get tense because you're saying something is wrong. Now, I want you to say, I'm in pain and it sucks. I'm in my house and I don't like it. I had eggs for breakfast and they were gross. Whatever it is that you're fighting, I want you to say, I had this or I have this and I don't like it. And that's radical acceptance, right? When we do that, then we're accepting instead of rejecting the reality. And when you say that, notice how your body relaxes a little bit, your shoulders relax a little bit, your chest, you're able to breathe a little bit easier. And that's because, again, we've stopped rejecting the reality. That's what makes psychology important. Your body listens to the messages that your brain sends it. And so while I can't talk you out of your pain, there are things that we can do to reduce it. So first we have to understand what is pain. Okay, so let's break it down. The International Association for the Study of Pain says it's an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. Pain is emotional as well as sensory. So imagine or remember the first time somebody broke your heart, right? Your heart wasn't actually breaking, but you felt that pain, not only in your chest, but a lot of people say they feel it in their stomach too. When you're emotionally distraught, your body can sense pain. And there is primary pain versus secondary pain. Primary pain arises from illness, injury, damage to the body or nervous system. I'm breaking my arm, I broke my finger, or I've got bulging discs, or I fell down, and then that leads to secondary pain. Secondary pain is the mind's reaction to primary pain, but often it's more intense and long lasting. Right? So a lot of times what we say is pain is inevitable, suffering is optional. And that secondary pain is what leads to the suffering. It's the mind's reaction to the pain. So here's a conceptual model of the transition from acute to chronic pain. You see the initial stimulus that causes the initial pain. You get stage 1 and immediately there's psychological distress. So think about burning your hand. How does that feel? Or stubbing your toe. What's the reaction that you get? There's a natural emotional reaction to potential for physical harm. Then it goes into stage 2, okay? The development of the exasperation of psychological problems. The form depends on the premorbid personality and the psychological characteristics. So if you already have some underlying mental health issues, then stage 2 can then be more impactful and more intense. And then finally, stage 3, where there's mental deconditioning, and you've got the acceptance of the sick role, exemption from normal responsibilities. You've already done the learned helplessness and the symptom magnification. And then there's a consolidation of abnormal illnesses and behaviors. So you can see how it goes from acute to chronic, and how that role of psychology definitely impacts that move from acute to chronic pain. So I want to show you the prevalence rates of the psychological distress within the chronic pain population versus the general population. If you look, major depressive disorder is 5 to 17% of the general population, but in chronic pain, it's 30 to 54%, and that makes sense. I expect people to come in with chronic pain with depression because they've lost a lot of things that they used to be able to do and can't do them anymore. Substance use disorder, lifetime, 16.7% in the general population. But if you look at the chronic pain population, current is 15 to 28%, and then lifetime is 23 to 41%. And a lot of times, you know, we talk about the opioid crisis and things of that nature, and 40% of overdoses for opioids are between individuals aged 40 to 65 who have started off taking medication for chronic pain. So it's important that we recognize in our chronic pain population that there are going to be some individuals who develop substance use disorder. Anxiety in the general population is 19.1%. In chronic pain, it's 16.5 to 28.8%. A lot of times we hear those what if thoughts, right? Like, what if I'm never going to feel better? What if this is never going to get better? What if I can't ever lay down or walk or whatever it is? They often catastrophize because the pain is so great. In addition, if they've lost their job, if they've lost, you know, the ability to be able to care for their family, that's going to increase their anxiety, as well as the fear of continued decompensation in their body. So anxiety is often pretty high in our chronic pain patients. And then finally, personality disorders. You've got 9.1% in the general population and 31 to 81% in chronic pain population. And we do see a lot of that personality disorders. We also have to look out for trauma. Trauma is definitely both medical trauma or abuse or accidents, car accidents. A lot of times these injuries started with a very traumatic event, and so we have to assess for trauma as well. So there are cognitive factors of pain. There are beliefs about pain, beliefs about controllability, self-efficacy, catastrophizing, and coping, and we're going to go through those as well. And then there are affective factors of pain: depression, anxiety, PTSD, and also anger. And we see anger a lot because when you don't feel good physically, you don't feel good mentally. And when you cannot control your pain, when it is chronic and out of control, that leads to frustration and anger. And so we also have to look at that. And so here's here's a nice little flow chart for you with the physical changes and the emotional changes and the stress and tension, right? So physical changes, their satisfaction will lead to emotional changes, and that could lead to depression. But notice how the arrows go back and forth, because your emotional changes will also affect your physical changes. And it's the same with stress and tension changes and the emotional distress there. What we're finding in our current environment with the COVID-19 crisis is that our patients are not doing well with social distancing and social isolation and getting out. And a lot of them have chronic and problems and suppressed immune systems. And so it's very important for them to adhere to the stay-at-home order. But what happens is their stress increases, and you can see when their stress and tension increases and the physical changes happen, as well as it's affecting their emotional changes. And so this is a really hard time for a lot of chronic pain patients, because generally the things that they're used to doing to make themselves cognitively feel better are not available at this time. So we're seeing a lot of patients have increased pain during the COVID-19 crisis because of the stress and the tension and the physical changes of their environment and the lack of ability to be able to do the things that they used to do. when you become stressed out, your entire body, but all your joints and all your organs become inflamed, and that's going to increase your pain. And so it's important that we recognize that and often give our patients as much, as we can, while keeping things safe and ethical. And so that's important to mention, particularly during the COVID-19 crisis. You could see the potential diathesis and predispositions. There's genetic predispositions, generalized biological vulnerabilities, generalized psychological vulnerabilities, and then there are social vulnerabilities. And that, depending on those diathesis and predispositions, that's going to play a factor in how an individual experiences pain, as well as how they develop chronic pain. And so I want to make sure that everybody understands that pain is chronic pain is biopsychosocial. Okay, so of course there's the biology of it, but it's also psychological. We can reduce pain by doing psychological interventions, and it's also social. When we are social creatures, humans are social creatures. And so it's important that even though, we're using the Zoom and everything like that, we remember that socializing is very important for our overall psychological well-being. And I know that right now everybody is kind of experiencing the lack of socialization, and it's very hard, even for individuals not in chronic pain. And so what we want to do is, if you notice there right down at the bottom of your right screen, we want to make sure that everything is balanced. And that's what we look for, is the balanced, because when things are balanced, there's a less increase in the central sensitization. There's fewer physical and mental health illnesses and symptoms. And so we want to work on and make sure that every aspect of this disorder is being treated biologically, psychologically, and socially. So what does this mean? Well, it means that as pain becomes more chronic in nature, psychological variables play a part in increasingly important role in the maintenance of the pain and behavior and suffering. Psychopathology of somebody is a significant concomitant of chronic pain. And so we have to look at that. If somebody has borderline personality disorder, they're going to catastrophize a lot more than somebody who does not have a personality disorder. And so we may see them a lot more than somebody who doesn't have a personality disorder. Both psych and they will often call their primary care provider or their prescriber with a lot of things that is catastrophizing. The biopsychosocial model has long proven to be the most heuristic approach for a better understanding. And so it's important to kind of look at that and understand the predispositions while you're treating your patients. And then the therapeutic and interdisciplinary pain program, they've been developed to use the biopsychosocial model, which has been cost effective, because when we add all the services, then what we see is an improved response to pain management. And that means less visits to the ER. That means less visits to the primary care. That means less doctor shopping. It means more involvement in the community. We've seen people go back to work, and that's huge. That's our goal, is to get people back to work and back into their lives. And so it is cost effective in addition to effective overall treatment. So what do? It says, talk to me. And I want you to remember the exercise in the beginning with the shoulds and the radical acceptance. There are several different treatment approaches and methods: motivational interviewing, cognitive behavioral therapy, acceptance and commitment therapy, exposure therapy, and group therapy that I'm going to discuss today. And what is not discussed today, but is also very effective, is biofeedback and hypnosis. And I do have good success with hypnosis. If you are interested in hypnosis, I recommend you have to be a healthcare provider, a licensed healthcare provider, to be trained in hypnosis, but I highly recommend the American Clinical Society of Hypnosis to start. And it's very important that if you do plan to engage in hypnosis, you do become certified to make it as ethical as you can. So let's talk about some of these other treatment approaches. The 5 principles of motivational interviewing, which I think every healthcare provider should learn. There is motivational interviewing for healthcare providers. I do that training as well at some point, but and there's motivational interviewing for nutrition and nutrition and fitness. There's motivational interviewing for everything. And essentially what it is you meet the client where they're at. But you learn these 5 principles of motivational interviewing: expressing empathy, developing discrepancy, avoiding argumentation, rolling with resistance or dealing with discord. They're called the same thing, and supporting self-efficacy. And so I'm not going to go through every question here that's on the screen. I know you guys are very intelligent and you can read, but here's some examples of questions that may evoke self-motivational statements in individuals with pain problems. We have problem recognition, concerns, intention to change. How would you like to be different? Knowing that if, a lot of times when I say, what would you like to be different about your life? And they say, well, I'd like to be out of pain. And okay, yes, you would. But what else? And what else? So if you receive treatment here, how would you know it was working? And then optimism is important to discuss with the patients as well. Cognitive behavioral therapy is very important as well. I always use motivational interviewing, but I also use a mix of cognitive behavioral therapy and acceptance and commitment therapy, along with DBT for some of my personality patients. But cognitive behavioral therapy is shown to be the most effective with pain management. It's problem-oriented, it's educational, it teaches self-management, problem-solving, coping, and communication. It's collaborative. It makes use of in-clinic and in-home practice. They do get homework. It encourages the expression of feelings and then the learning to control of that feelings that impairs the rehabilitation of the patient. It addresses the relationship among thoughts, feelings, behavior, and physiology, as well as your actions and your reactions. And of course, in CBT, we do anticipate setbacks and a lapse, but it also teaches the patients how to deal with these. And so it's been very, very effective treatment for chronic pain. You can see the goals of cognitive behavioral therapy right there. Again, I'm not going to read all of them to you. But one of the biggest things that is important with CBT is that we encourage the patients to attribute success to their own efforts. A lot of times I'll have people come in and say, you've done all of this for me and I'm so grateful. And while that's awesome to hear, I didn't do anything. 1 hour a week or every 2 weeks with me is not going to make the difference of the patient getting better. The patient's follow through on the things that we discuss in the session is what's going to make the patient better. And so it's important that we always toss it back to them. Toss it back to them. It's your efforts, your ability to do the things that we've discussed in therapy or the session or the doctor's office that have made you succeed in your life. And so it's important that we do that. Acceptance and commitment therapy, the basic premise is by accepting and learning to live with pain, one can limit the effect that it exerts over his or her life. Okay, and then the essence of therapy, this therapy ACT, I almost called it ACT, guides individuals to change their expectations from the elimination of pain to living as well as possible with pain. So it's more acceptance, and once we accept it, remember that exercise in the beginning, then it's easier to manage, right? So with ACT, we use metaphors and experiential exercises. Individuals learn the futility of control-oriented strategies and the benefits of acceptance-oriented strategies in response to negative internal experiences, such as pain and discomfort. So we're looking on more acceptance of that pain to then move forward. Because again, when we reject the pain, your body goes into fight or flight, and will then make the pain worse. Also in ACT, individuals are encouraged to explore their personal values and set goals consistent with those with their values. So what is it they value? And so a lot of times it's moving, wow, that hand was big, moving from one way to the other, moving from your value, working with the values to improve the overall quality of life. And so it's moving that attention from the pain to more positive things. That's what I was meaning to say. Here's the ACT treatment processes. Experience thoughts and feelings. We work on detecting, knowing a thought or feeling is present, registering the content, understanding the message of the experience, believing or heeding it, taking it as true, and then fuse it, contact it as the only experience present. So the difference between ACT and CBT, a lot of times I like to use this metaphor. CBT has, imagine two sides of a battle, if you will, with bows and arrows. CBT is combative, right? So you've got all these negative thought arrows coming, and CBT is combating them with positive thoughts. With ACT, looking at those arrows and those negative thoughts, it's just a matter of saying, well, that's just an arrow. I also have another one. I don't have to pay attention to that one. So thoughts are just thoughts, and we assign value to them. And if we don't like it, then we can often change that or not value that and just throw it away and get another thought. And so that's kind of, in a nutshell, one part of ACT. I'm not going to go through the whole thing, of course, but you understand, please, that the difference between CBT and ACT is CBT is combating negative thoughts with positive ones, and ACT is recognizing thoughts as thoughts and allowing yourself to then assign a value to that, whether it's one that you want to recognize and hold on to and move forward, or a thought that you want to throw away because it's not helpful. Exposure therapy. Exposure therapy is very helpful because it allows the patient to get used to a lot of things that are uncomfortable. And so if you look at the model, you can see the injury and the strain leads to the pain experience. If that individual then catastrophizes about their pain, it goes to fear of movement, and it can re-injury and more pain. Then at that point, that individual is hypervigilant about the pain, and they will do anything to avoid or escape the pain, which then increases the pain experience, but can also go into disuse of the body, disability, and of course, depression, and it becomes a circular model because of the fear of pain. Now, if there's an injury or strain and the pain experience happens, and we can reduce the fear immediately or address the anxiety about the pain so that it does not go into catastrophizing, it becomes low fear. Then we can do some exposure therapy with that, allowing them to face that low anxiety, that low fear, and lead to recovery. And so that becomes very helpful. We look at a hierarchy of feared activities. There's an explanation of a treatment approach. We select activities with appropriate level of difficulty. Obviously, I'm not going to, ask somebody with chronic pain to do TRX, but I might ask them to do chair yoga for their body, because we know that yoga strengthens the muscles and the bones and actually has a reduction in chronic pain. We need to specify the target expectancy and predicted outcome, have the patient rate the credibility of the expectations. We talk about safety. We normalize pain during the exposure activity so that they don't, go into more panic, and your body then gets used to it. There's confidence in both the patient and the practitioner, and we're going to monitor changes in expectations and emotional state. Again, talk about safety and then repeat. Group therapy is also very effective. A lot of these patients are isolated because they don't have a lot of social interaction with others because of their chronic pain. So that's where group therapy becomes very helpful. There's 4 major goals in group therapy: teaching pain coping skills, educating patients about their pain or disease, providing social support, which is huge, and teaching mindfulness and acceptance-based strategies. Group therapy allows patients to understand that they're not going through their chronic pain together. They're not alone. Sorry, they can go through it with a group together, and that there are other people that are experiencing something similar to what they're experiencing, and that camaraderie becomes very important in addressing depression, anxiety, and other things. So the specific goal of group therapy is important in determining the basic format and structure of the group, the type of patients treated, and the level of training required by group therapists. Obviously, somebody with fibromyalgia might not be an appropriate group therapy candidate for a back surgery group therapy. And so you might have 2 different or 3 different group therapies depending on the type of chronic pain, and depending on the population that you're serving. So there's cognitive skills training groups, patient education groups, social support groups. We need pain coping skills training groups as well. They are short term, only 8 to 10 weeks. And remember that not everybody is appropriate for group. Most appropriate patients are those that accept the fact that their pain is likely to persist. So they've already accepted that they're going to have chronic pain, and who are open and willing to learning new pain management skills. Does it work? Research consistently shows, of course it does. And otherwise, I wouldn't be coming to you today presenting on this. With the reduction of psychological symptoms, there's an association with pain reduction, and there is good evidence from trial and evaluations of programs to indicate that psychological treatments are efficacious and effective. We also need to, in future research, refine the formulation of pain and attempt to make it explicit links between the process of psychotherapy and the outcomes. And this is bad therapy. I don't, you know, that cartoon's funny, but it's bad therapy. But unfortunately, there are some therapists like that. So that's all I have about this. I went through it, kind of fast, faster than I usually do. So are there any questions? Okay.
Yeah, I haven't had any come in the Q&A yet, or the chat. If anybody does have any questions they'd like to submit at this time, please do. If they have questions after the presentation, are they able to reach out to you, or is there a resource you'd like to provide for them, Dr. Hutchens?
Absolutely. If you want to reach out to me about anything in the presentation or anything else, please feel free to email me at jhutchens, Hutchens, that's JHUTCHENS, at HutchensAssociates.com.
Excellent. Well, we really do appreciate your time today. A lot of great information on here. Again, we have recorded and we'll be posting to our YouTube channel. I should have said earlier, you know, since it's Friday, we won't have it posted by the end of the week, but it will be posted by the start of next week, and able to be viewed at any time from our website or by searching Indiana Rural Health on YouTube. You can find our channel. Just greatly appreciate everybody taking some time out of their morning to join us, and greatly appreciate your expertise and willingness to present for us, Dr. Hutchens. Thank you so much.
It's my privilege. Thank you for having me.